this is a really critical piece that I think we can't overlook. And the veterinary community as a whole is grasping onto a little bit more. But what really makes pain an individual experience is your emotional response to pain. And so pain has this intimate relationship to depression, anxiety, fear, and an overall decreased quality of life. And we have some really good studies on the human side. And there's actually a few coming out now on the veterinary side, a few about Cavalier King Charles who have syringomyelia and recognizing changes in their quality of life associated with neuropathic pain. But it's coming. And this anhedonia is, I think, going to join allodynia and hyperalgesia as a symptom of chronic pain. And it essentially means no longer finding joy in activities in life. So kind of a profound term, but really, I think we see this in patients who have chronic pain. And so some of these changes are structural in the brain, but some of them are emotional and can be chemical as well. There's certain things we see when patients are suffering from chronic pain, and I think these are a lot of the things owners see. Sometimes they're more sensitive to noise or other stimuli. They don't like being brushed. They don't like being pet. They don't like playing or interacting. They don't sleep as well. They're withdrawn. They don't seem as motivated. There's this very classic syndrome called learned helplessness, where they kind of give up trying because they feel like they're not going to feel better. So the focus of this summit and this series is on osteoarthritis, which we don't think classically as a maladaptive or neuropathic pain syndrome. But when we dig into the human literature a little bit, this is from a physical therapy journal, we see that there's actually a very close relationship between neuroplasticity in the central nervous system and musculoskeletal disease. So I think when we're going to pain manage, which is a critical piece of our management of these patients, we have to think of them as neuropathic pain patients. So when are we reaching for this multimodal pain management approach? And this is when we're dealing with complex pain patients. And I do feel like a patient with osteoarthritis falls automatically into that category because they didn't just get it yesterday and they're not going to get better from it tomorrow. So their nervous system has been dealing with this issue for a long time. And every patient's nervous system responds a little bit differently, and certain areas may get more fired up than others. And recognizing that on your exam and through your history can become really important to individualizing treatment. Some of these patients also have comorbidities that limit our drug choices. So we need to have a lot of different options when some might be cut off because of pre-existing liver disease or renal disease or diabetes or Cushing's or whatever comorbidities these patients come with. And so we can be innovative when this pain is more severe or complex. So interestingly, today I'm focusing on pharmaceuticals, but I can't go any further without stressing how important non-pharmaceutical management is as well, which we touched on a lot last week. So I think it's really important to take away from this that I'm not stressing to only use drugs, but drugs are part of a integrative pain management plan.